what's the most likely diagnosis here? Like, what's the most likely cause? What do you need to know about the vomit? What are some of the red flags that you don't want to miss? And what are we going to end up managing for this kid? So I'll give you just a little bit of time. I'm a big believer in like physically committing to an answer. So if you can jot it down on a bit of paper. 18-month-old with vomiting and a sick contact. All right. Hopefully you've got a few things scribbled on a bit of paper. All right, so what do we need to know? Hop down, sorry. I'm just going to put my dog outside. Mate, let's go. Come on. All right, sorry about that. All right, what do we need to know? So you've got a kid at home with a sick contact and vomiting. The most likely cause is going to be gastro, yeah? So really important to keep that in the back of your mind. And if it was writing down for your OSCE on the bit of paper, I'd have this circled in the top right-hand corner. So it's most likely gastro, but that's really a diagnosis of exclusion. So I think really important as soon as you ask about the vomiting, you're going to get like one of sort of three type of pictures from the parent, or you're going to get this, it's like a paucity regurg, like this sort of like little bits of vomit that just keep coming up called posits. You're going to get like, oh, it's just like normal vomit. It's just food coming back up, or it's like full on projectile type vomiting. Projectile vomiting is quite typical of pyloric stenosis, but it's pretty common in OSCEs as well. And then what's in the vomit, and this will sort of align with the pattern of vomiting. So if it's like these little paucity vomits, they'll often be like milky or little bits of food that they've just eaten. Or if it's like normal vomit, that's food, that's what we're thinking. Or if it's like got bile or blood in it, that's when we're thinking it might be sort of like a surgical type problem, which is what we'll focus on a little bit at the end today. Okay, so then what could it be? And as I said before, like the picture of the vomiting that comes to you on the history is really going to fit in quite nicely with the origin of the condition. So if it's like an infection type thing, often they're going to be febrile. They often have a sick contact at home, like Travis does in this case. They have coryza or lethargy. And so then really important, as soon as you get this sort of fever infection type picture, you just go top to toe. You start with the brain, you ask about, like, have they had seizures? Have they been flat? Blah, blah, blah. ENT, so you have a look in their ears, nose and throat, listen to their lungs, gut, and urinary tract. And I guess in this case, we're thinking it's a gut source. The other picture you might get is that it might be over a much longer time course. So like it's actually been over a couple of weeks now. It's often after meals. As I said before, it's that paucity type picture. They might have a rash or some frothy stools. And so that's where you're thinking it's more of these sort of like functional type pathology. So that's like your reflux, celiac disease, or your cow's milk protein intolerance. So that's another picture. The other picture is, like I sort of said before, is like if the vomiting has like blood in it, or it's projectile, or it might be bilious or really quite acute and they're really, really distressed, that's when we start worrying about sort of like Paeds surge type conditions, like pyloric stenosis, atresia, intussusception, blah, 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 blah. You know, again, as I said, this is what we'll sort of focus on toward the end of today's talk. I'm a big believer in trying to memorize as little as possible. So the main aim of today is to give you a bit of a structure to type thinking. How can I think about each of these conditions in particular scenarios or particular times? And then other things when it comes to vomiting, just important to make sure, have they had head trauma? Because that can often cause vomiting. Do they have an aura? Like, is this a young kid with their first migraine, polyuria or polydipsia for a first presentation of type 1 diabetes? Okay, so infection, functional and anatomical type things, often very distinct as soon as you ask, like, tell me a little bit about the vomiting. Okay, so back to Travis. So when you question a little bit further, he's got a fever of 38.5. He has no suggestive history of sort of like focal infection in his ears, nose, and throat, or in his brain. He also has loose bowels. So we're thinking, okay, it might be a little bit of a GI picture, which fits. Mum describes the vomit as it's normal blood, normal vomit, no blood or mucus. He's a bit lethargic and has a bit of tummy pain. He's had minimal to eat or drink, and he was 15 kilos at his last check 2 weeks ago, which I've since realized is like a very big baby, but that's fine. It needed to be that way for some calculations later. Okay, so boom, straight away we're like, okay, this kid has gastro with a sick contact at home and all of the clinical features that align with that. But there's one other really important part of this history that you would need to pick up on, and that's that he's had minimal to eat and drink. And so for many surgical type conditions, and this goes on to more than just Paeds, part of the diagnosis is also dehydration. So we really need to manage that and also take a bit of a history of that as well. So you've probably done this before, and you might have read it in Tally and O'Connor, but really important to be able to take a good sort of like fluid balance history, and be something that you'll need to do as an intern as well. So taking a history, and it goes back to really simple principles, is you just ask them how much has gone in, how much has come out. So for kids, it's how much have they been drinking, how regular have their feeds been, are they eating and drinking normally, or have you noticed something different? Then you can think, okay, so how much fluid is going out? So it'd be important to question the parents about like how much diarrhea, like how many episodes, has it been like overflowing the nappy? And maybe you can even try and estimate how much vomit, urine, or sweat. Just try and think of all the ways that we can lose fluid, just to get a picture of about where, how dehydrated they are. And I'll give you a little bit of a hint about how to do that, sort of giving a numerical value for that in a minute. And then nappies, as I mentioned before, it probably goes in with the fluid out type picture, but wet or dirty nappies is good. And one of the big sort of buzzwords that you can say to a consultant is like they're continuing to have dry nappies is sort of like a flag for dehydration. So when we're examining now for Travis and his dehydration, mental state, I'm sure one of the first things you start to learn in Paeds is like just that head of the bed type assessment is like, what do they look like? Like if they're lethargic and a little bit unsettled, all the way down to like floppy and really moribund. Okay, weight loss. This is why I had weight loss in his little vignette. That's because weight loss is really important for when you go to rehydrate Travis. So there's amazing tables on RCH about how to sort of estimate and give a value, but this is, maybe this is a Ben fact, but this is sort of like how you gauge about where they're, how dehydrated they are. So if you take the history and they're like, oh, okay, so he's been vomiting, he's got diarrhea, and you're like, oh, okay, so he's got a pretty high risk history for dehydration. They're about 3% dehydrated. So they've probably lost about 3% of their body weight. If you take the history and oh yeah, they've got this high risk history. And then when you do your examination and you look and they've got reduced skin turgor and maybe some sunken orbits and they look a bit dry around the lips, so they've got a few clinical features, then they're probably about 6% dehydrated. And then if they're like severely dehydrated, affecting their mental state, then they're probably around that 10% of their body weight that they've lost through dehydration. So as I said, you look it up, but this is like a good ballpark because we'll start replacing this weight loss that they've lost when we talk about how we rehydrate kids. Okay, so high risk history, no symptoms, 3%, couple of symptoms, 6%, severe, 10%. Not too hard. All right, and then I just sort of picked out some of the major clinical features. So you can test capillary refill, you can assess their skin turgor and to see if it's sort of like reduced, look at their vital signs, but vital signs are probably a really kind of end stage picture. Maybe the heart rate goes up first, but you definitely don't want to be seeing a drop in blood pressure. Dry skin, sunken orbits or fontanelles if you're dealing with really young kids, and dry mucous membranes. I think dry mucous membranes is probably a really good one. Get them to stick out their tongue, and that's a pretty sensitive sign. Okay, so you've done your history, you've done your examination, and you're like, okay, I wonder how dehydrated they are. So if we go back to Travis, he's probably got a bit worse while we've been doing this, but for the purpose of today, he's lethargic and floppy. He doesn't engage when you try and take a bit of a history or talk to him. He has dry mucous membranes, reduced skin turgor. He's got the works, and he hasn't been taking in anything orally. So based on these findings, I'll give you another minute. Hopefully you can just jot down a few things on a bit of paper, like what are you going to do in an OSCE if you got this this sort of picture for a severely dehydrated kid? What are you going to do? This was a previous OSCE the year before I went through. I would have gone, put in a cannula, give him some normal saline, done. Maybe do a fluid balance chart. That would have been the extent of my answer, but there was a bit more. This is probably one of my like most useful things that I have learned in Paeds in 4th year, was this rehydration. I don't know. It's not a recipe. It's just like a bit of an approach. All right, that's 45 seconds or a minute. Hopefully you got a few things down. This is how to do it. I really like this. So let's get into it. So really, there are 3 questions you need to answer for rehydrating any patient, be that a kid or be that an adult. So how are you going to give it? What route? What fluid are you going to use? And how much fluid are you going to give? Are the 3 questions you need to ask. Okay, so we're going to go kids specifically here, but keep in mind that this can apply to adults. So 3 routes that you can possibly give. You can just do oral. So if they're tolerating oral fluids, then that's probably the first line that you would do. So for kids, water is great. Breast milk is also fine, or oral rehydration solutions. I definitely think you could get this as a counseling station. So important to say, like, try and avoid anything artificial, like fruit juice, soft drinks, sports drinks, or anything like that. Keep it to water, or like electrolyte drinks, like like the Gastrolite or something like that. Okay, then the second line, importantly to keep this in mind. So second line is nasogastric rehydration for kids, if they'll tolerate. And that's really because it can actually help settle the vomiting. So if you're just dripping small amounts of fluid through the NGT, you can actually help settle the vomiting and that inflammatory response that's probably happening in their gut. And the other good thing is that you can give ondansetron. So ondansetron is the first line antiemetic that we use for kids. And I always remember that because it's like sounds like a transformer, like ondansetron kind of sounds like a transformer, and kids love transformers. So that's the first line, the one that you give. Like metoclopramide's a pretty shit sounding transformer, so that probably wouldn't work. Anyway, the other one, and then IV is the third line. And really indicated in a severely dehydrated kid where you're probably going to need some sort of fluid bolus because you're worried about them right now. So this is the findings from Travis. If you're worried that he's lethargic, floppy, he's not engaging, like really this is pointing at an IV rehydration type picture. So 3 routes in that order is good to know that they're there. Okay, now with what? Now this bit is a little bit PAED specific because doing 5th year at the moment, like it's pretty different about when you would use particular fluids. When in doubt for adults, use normal saline. You can't really go wrong unless they have some pretty funky things going wrong. But for kids, there are 3 different things to use. There's normal saline, so 0.9% normal saline. There is a bag of normal saline with a bit of dextrose added. So 0.9% saline with 5% dextrose. And there is 0.9% saline with a bit of potassium chloride added. So 20 millimoles of KCl. Now, those are the only 3 things that we use in kids, just those 3 fluids. And I'll tell you about where to use each one in a second. But that's all you need to know. You don't worry about Hartmann's, don't worry about any of that other shit. Just remember these 3 things for kids. Okay, now how much fluid are we going to give? There are 2 components. The first one is like, do they need a bolus right now? So it sounds like Travis is up shit creek, like he's lethargic and it's affecting his mental state. So you're like, bam, 10%, he needs a bolus really quickly. Now, when we give a bolus, that's what I already said, we give it when we're really worried about them. And this is how we do it. So this is the only place where we use just normal 0.9% normal saline. So bolus is the only time that we use just normal 0.9% saline. And you do it 20 mils per kilo bolus. So for Travis, it would be 15 times 20 mils would be your first, because he's 15 kilos. That would be your first bolus. Then you reassess, and then you can give a second one if you need it. But really just important to know normal saline for your bolus. Okay. Then the other component of your rehydration is like, once you've given them the bolus to sort of like stabilize their blood pressure and make them okay right now, we need to think, okay, how much fluid have they lost? Yeah, how much they've probably coming out of the community into ED. And when we did their examination, we were like, shit, he's probably like 10% dehydrated. So 10% should correlate to a particular weight for them. For him, like if he's 15 kilos, 10% will be like 1.5 kilos. And so we need to replace the number of grams that he's lost in mils of fluid. Does that hopefully that sort of makes a little bit sense? You just like replace exactly what they've lost based on your estimate in mils of fluid. So as I said before, this is just that my sort of guide, and you can look it up on RCH if you want a really specific example. And we need to replace how much they've lost in the first 24 hours of their admission. So you don't need to give it straight away. You just give it as an infusion because they're being IV rehydrated over the first 24 hours. So as I said before, Travis is 15 kilos. And if he's severely dehydrated, that's about 1,500 grams. And then, so over the first 24 hours, we need to give him 1,500 mils of 0.9% saline with 5% dextrose. So when we're replacing the deficit, we use normal saline with 5% dextrose. When it's a bolus, it's just normal saline. Okay, hopefully I'm repeating myself a little bit and you're starting to acknowledge that, which is good. Okay, so that's the concept of replacing the deficit, is how much they had lost. The second part that we need to do is be like, okay, so they're not drinking anything. So we need to give them enough fluid to cope for the full day if they're not drinking anything. So they're called maintenance fluids. You might have heard this in third year or hopefully a bit on Paeds as well. The way that we calculate how much fluid they need is this 150-20 rule for their daily fluid requirements. So what you actually do is you go 100 mils per kilo for the first 10 kilos, 50 mils per kilo for the second 10 kilos. And if there's any kilos left after that, you go 20 mils per kilo for everyone after that. And just like the deficit, we're going to use 0.9% saline with 5% dextrose for that one. So easy to remember because it's the same as the fluid deficit. So this is how much they need over the day if they're not drinking anything. So Travis was weighed, we knew he was 15 kilos 2 weeks ago. So his daily requirement, so this is, if he's 15 kilos, he gets 100 mils per kilo for the first 10. And then for the next 5, he gets 50 mils per kilo according to that 150-20 rule, which ends up with 1.25 liters. But remember, on the first day of his admission, we need to replace the deficit. So on the deficit, he gets the daily fluid requirements for that day plus the deficit. And then on the second day, he just needs the maintenance fluids because we've already replaced the deficit from the day before. Hopefully that starts to make a little bit of sense. Obviously, these slides will be available to you if you want to go slow or put me on 0.25% speed if I'm going too quickly, and you can watch it back. Okay, and then the last component of rehydration is like we need to make sure that anything that they're losing ongoing is replaced, or the electrolytes that they're replacing is replaced mil for mil. So you say to our lovely friendly nursing staff, can you start a fluid balance chart? And anything that they continue to lose on the ward, could you replace that mil for mil every 4 hours with this normal saline plus 20 millimoles of KCl, which is just sort of like electrolytes. Okay, so that's rehydration. So it's really just bolus if they need it, and then the deficit, what they need every day, and any ongoing losses we replace with sort of normal saline with a bit of electrolytes in it. Boom. All right. Okay, we're getting there. All right, so now what happened? So that Travis was more that sort of infective type picture when he came in. What if it was more this, like, this morning he woke up and he was acutely vomiting. He was really sore, really stressed. I don't think he's been passing stools for the last couple of days. You're worried about these surgical type conditions like pyloric stenosis, atresia, yada, yada, yada. So the main aim of this type of patient or this type of picture is, like, you need to work out what the cause is or get them to someone who can fix it. Because often if they progress, it can be really poor outcomes. So as I said before, I'm a big fan of not just like going through all those conditions and trying to memorize all the buzzwords, because there's lots of other shit in med that we need to learn that does require that sort of memory. So I've got a few different strategies here to like help you work out which one. Now, the first one is the age. So this timeline is awesome. From birth to 2 weeks, 2 weeks to 2 months, and then beyond 2 months. So anything that happens in the first 2 weeks of life, and this goes for most things, is sort of like congenital. Yeah. So for gut-related things or ped surg-related conditions, that's going to be like your atresias, where there's like something that just didn't develop properly during development, like malrotation with volvulus has a congenital component, Hirschsprungs, where the last port of the bowel doesn't develop properly. Like all of the things that present in the first few weeks of life all have a congenital component to them. Stuff that develops after 2 weeks, that's sort of like something they have to come out of the uterus and then go on developing for it to progress. So for things like pyloric stenosis, where that last part of the stomach becomes sort of thicker and thicker and thicker, like that's stuff that's happening. That's not a congenital sort of condition. Intussusception sort of happens between 2 months and 2 years of life. Beyond sort of 2 years, you're thinking like, is this them presenting with appendicitis or late intussusception? And sort of like up towards adolescence, we're thinking, okay, this could be appendicitis or testicular torsion, or maybe a late presentation of Hirschsprung's disease. So hopefully that sort of approach, you can get rid of lots of EMQ options just by looking at the first like 2 words, like a whatever age child. All right, the other big clue that you can get is like, what sort of a clinical picture is this kid presenting with? Do they have like an upper GI picture, or do they have a lower GI picture? And again, you can then like start knocking off a whole bunch of answers because they don't present typically of this upper or lower type picture. So upper type picture is sort of like small bowel upwards, up to the mouth, I mean. So that's going to be things like pyloric stenosis up in the stomach, small bowel atresia, where there's like a gap, like a blockage in the small bowel that's sort of congenital, malrotation with volvulus, where the small bowel twists, or intussusception, where the small bowel sort of telescopes on itself. So again, all those proximal type pictures. The main thing they're going to present with is vomiting. Yeah. So they're often going to have like bilious component if it's below the level of the ampulla where the liver drains in. It will be non-bilious, obviously, if the obstruction is above that. And then the bloods that we're going to look at is often when they're going to have metabolic derangement, because they haven't had enough time to absorb things through their small bowel yet, because that's where the obstruction is. Conversely to that is, do they have like a distal type picture? So sort of from like the large bowel down. Now, because the pathology is lower in the GI tract, that's going to be things like your hernias, which is often large bowel, like a meconium plug blocking the gut, Hirschsprungs or anorectal malformations, which are right down here in the anus. Now, the major thing they're going to present with is because you've got all this bowel all the way back up into the small bowel that's normal, but you've got a blockage down the bottom. The main thing that's going to happen for these guys is they're going to have abdominal distension because it just backs up and the pressure increases. We're going to do an abdominal X-ray, which I'll show you how to interpret a little bit in a sec. So abdominal X-rays, I'll show you how you can differentiate very, very like abdominal X-rays for dummies, because I don't claim to have anything else above that. Proximal pathologies. So for kids, normally, if you remember the third year, you can tell the difference between like haustra on the large bowel and those volvulus comitantes or whatever they're called. I can't really remember. But kids don't have that. They haven't developed yet in kids. And so the best way to tell the difference about, do I have a proximal pathology or do I have a distal pathology, is to draw a line through L4, like the level of the umbilicus. And if the majority of the bowel or the gas pattern that you can see is above the line that you've drawn at L4, then it's probably proximal, and you can say it's probably small bowel or above. Whereas on the right-hand side over here, if it's a distal pathology and you draw that line, you can see all the gas is below the level of the line. So you can say, okay, so it's probably a distal pathology affecting the large bowel, the last part of the small bowel. Really helped me just to like eyeball something and you can straight away go, boom, this is probably top or probably the bottom. All right, we're nearly there. At the bit that everyone wants is the buzzwords and how to get all the EMQs right. But there's one more thing I think can really help you for OSCEs. And this is what I call my like surge workup. Again, take this into adult medicine because it's great. So there are 2 talking things that you do for every patient, 2 oral things that you do for every patient, 2 IV things, and 2 medical things that you do for every patient. And if you just like, this is 99% of your management plan. So even if you get to the OSCE and you're like, fuck me, the double bubble sign, we had that in our OSCE. I can't remember what pathology that was. And then the question is like, what is your management plan for this kid? Like, you don't just have to remember the answer for duodenal atresia and the specific surgery name. You can get 90% of the marks here and show that you're really competent just by doing this sort of basic surge workup. Okay, so the 2 talking things is refer to the surgical team and explain to the parents. Straight away, really easy. They're the 2 people you're going to talk to. The 2 oral things for the kid is you're going to make sure you keep them nil by mouth. And you're going to put in a nasogastric tube to hopefully decompress the stomach and get, because they've probably been eating or they've been trying to eat or something like that. So to decompress the stomach or drain the stomach. The 2 IV things, you're going to cannulate them, or you're going to get the pediatric team to get a cannula in and take some baseline bloods, because particularly if they're going to go to surgery, it's really important to know their baseline. And you're going to start IV rehydrating them. So we're all over this now because you know that you're going to give them a bolus if they need it. You're probably going to replace the deficit, and you can probably calculate their daily maintenance fluids as well. And the 2 medical things, analgesia and an antiemetic. So even if these are all half a mark, yeah, that's like 1, 2, 3, that's 4 marks and maybe 1 mark for the name of the surgery. You've just got 4 out of 5, like 80%, like boom, like it's all pass fail at the moment anyway. So you're absolutely cruising. All right, how long have we got? 15 minutes, perfect. So now let's go through the pathologies, but hopefully now you've got this like, okay, so I know it's going to be top or bottom. I know it's going to be, I know it's like, I can look at the X-ray and work it out, or I know if this is like an infectious type picture, or I know if this is sort of like a anatomical type picture, and hopefully you'll start to see the patterns as we go through them. Okay, first question is duodenal atresia. So this is because, again, it's congenital. So it's going to present within the first, like straight away after birth, within the first few days after birth. And really what it is a congenital sort of stricture or a congenital sort of absence of the lumen of the gut. So often it happens in the duodenum down in this bottom part. And you just have this congenital blockage. 80% of them occur below the level of the ampulla vata, where the biliary tree drains in. So that means the bile can come into the duodenum and then come up, and then they can vomit it out. So on a clinical picture, they're often, the yellow words are the buzzwords that I reckon you should try and keep in mind. This is the well bilious vomiter. Yeah. So when I say well, because if I just go back to that picture, can you see how like nothing is dying, nothing is like nothing is stuck or necrosing or anything. It's just like a congenital. It's just them. So they're not going to be actually in acute pain. You just like once you feed them, they just vomit it back up because like there's just nowhere to go. It might be a narrowing, so it might not be like straight away, but it'll definitely happen within the first few days. So these guys are well, they have bile coming up. So it's like this green or yellowy type vomiting. There may be some clinical indication about their pregnancy. So maternal polyhydramnios, and that's because the baby, while it's in utero, tries to swallow, but it can't. And so it doesn't reabsorb some of that amniotic fluid. And big association here, so 30% of them have trisomy 21. So a mark in our OSCE was to say further long-term management for this patient would be to refer them for genetic counselling or genetic investigation. Okay, so investigations for these guys, when you do an abdominal x-ray, the big one is this double bubble sign. Really, that's because, and again, draw a line through the umbilicus and you can see the big bubble is above that level, so it's a proximal picture. So you can see the first bubble here is the part of the descended part of the duodenum, and the second bubble is the stomach. So they're the two bubbles on the abdominal x-ray. You could do an upper GI contrast study where they swallow some radiopaque contrast, and you probably just see that it doesn't go down or it goes down really slowly. Management, so like boom, your baseline surgical workup is we went through before. So your two talking things, your two oral things, your two IV things, and your two medical things. And the name of the surgery is very fancy, duodenogegoscopy, which is basically where you just take out the piece of stricture and you connect the duodenum to the jejunum in the small bowel. And you could consider karyotyping because of this association with Down syndrome. So like boom, not too bad. The good thing about ped surg conditions is like what's here on the slides is probably enough, yeah, because we don't need to know them in too much depth. Okay, so the next pathology is malrotation with volvulus. Now, again, has a congenital component to it because their bowel hasn't twisted around properly in utero when it's developing, and so it presents within the first few days of life, but it can be a bit later, and I'll sort of explain that why that is in a minute. So malrotation with volvulus, two components as the name kind of suggests. Malrotation, now, I don't know, I love this. I thought this was really cool. Basically, when the gut's developing in utero, it sort of comes out through the umbilicus and sort of twists. And then when it goes back into the gut, it twists again. And the twisting of the bowel sort of in utero sort of opens up and establishes the omentum on the back of the abdominal wall. I think I have a picture of it. So what basically happens for your small bowel, it normally has this nice wide attachment to the posterior abdominal wall. And if the rotation doesn't happen enough, so the malrotation part, when the gut comes back into the wall, if it just sort of sticks onto the back wall, you end up with this really narrow attachment to the posterior abdominal wall. And because it's all sort of suspended in the omentum, what can happen is the small bowel can just twist on that sort of narrow base. And that's how you get the volvulus and the sort of acute bowel obstruction. So the malrotation is the congenital part, and the volvulus is when it sort of twists on itself and causes obstruction. So you can sort of see why like it might present sometime in the first few days, because it might like twist on itself and then untwist, and then it might take a few days for it to twist to the point where it obstructs the whole gut. Okay, so now that we've got this twisting component to it, there is something that's like stuck or twisted or necrosing or like undergoing acute inflammation. So these guys like might have this a few day history of irritability where the gut's twisting on itself, and then once the volvulus actually occurs, they have bilious vomiting because their small bowel is obstructing and the bile has to go up and out. And then because it's acutely twisted and obstructed, they're really, really uncomfortable and they draw their legs up. And yeah, they look really, really distressed. So to differentiate that from duodenal atresia, where it's just a congenital stricture, they're the well bilious vomiter, but the malrotation with volvulus, these guys have acute volvulus. So they're going to be like the really unhappy bilious vomiter. On the investigations, I think the main buzzwordy one is the upper GI contrast study, where they get this sort of corkscrew appearance. And I think that's because they've got this volvulated small bowel, and you can sort of see this corkscrew. You have to have a bit of an imagination, but that's what it sort of looks like. So the corkscrew appearance for malrotation and volvulus. The management, like boom, there's your 4 marks worth of baseline surgical management. And they often need a few procedures. The first one is called a LAD procedure, where they go and they cut the abnormal mesentery onto the back, and then they re-establish it. But I think as long as you know this LAD procedure, so that's getting rid of some of these adhesions, that's the one that I've seen come up in EMQs in the past. All right, the next condition, so this one's called Hirschsprung's disease, and you can see that we're very much going in chronological order about when these would present. So Hirschsprung's disease is a distal pathology, but again has a congenital component. You might have seen the name as distal colonic agangliogenesis. Basically what happens is, if you remember back to when we did gut anatomy way back in the dark ages, they have this, the myenteric plexus, those muscular nerves that run between the layers, the circular and linear smooth muscle in the gut. Those myenteric nerves that run in that plane, they develop from proximal to distal. And so when they don't completely make it all the way to the anus, that's when you have this like section at the anus that has no myenteric plexus, and therefore basically doesn't contract and doesn't push fecal matter through. So if that portion is really, really big, I think I've got a picture of it here. Yeah, so like this is a, so if that portion of agangliogenesis, no myenteric nerves, is really, really big, poo gets stuck in this sort of, the section that does work, and that just dilates and dilates and dilates. And that's where you see that, that characteristic megacolon. And sometimes that can get infected because it gets dilated and necrotic. And that's where you might have seen toxic megacolon, which I just think is the most awesome name for a pathology, toxic megacolon. Again, so this one also has an association with Down syndrome. So we had Duodenal Atresia and Hirschsprung's from this talk so far. And I guess it's also common with very preterm infants because they just haven't had enough time to develop yet. Okay, so clinical history, they have a failure to pass meconium. So often the 2 main diagnoses that we worry about are cystic fibrosis and Hirschsprung's disease. Cystic fibrosis because they have a plug that they can't pass. And sometimes with Hirschsprung's disease, if they have a really short affected segment, they can actually like have ongoing constipation all through childhood, and then it doesn't get picked up until much later on in life. But from a ped surg perspective, where you're called to see a patient who hasn't passed meconium, you're probably more worried about Hirschsprung's disease, and they have a big segment that's not working. On examination, there's this gross thing called a squirt sign, where you do PR examination, and then that basically opens up the anus, and that causes like acute loss of fecal matter. This is not a baby with Hirschsprung's disease, but I just found a baby with abdominal distension who looked kind of unhappy, just to show you what that might look like. So investigation. So the gold standard for this one definitely is a biopsy. Definitely is a buzzword. Is called a rectal suction biopsy, and that's what they do. Is they just put a little suction probe into the anus and take a suction biopsy from the piece of last part of the anus, and then they look for those myenteric nerves to see if they're there. And so this, when you do an X-ray on them, you can sort of see all that distension is proximal and down in the lower part of the abdomen. Management for these guys, baseline surgical workup as we've been through, and the procedure to remember is called a pull-through procedure, where they basically chop out the piece of aganglionic bowel and pull the bowel down to the anus and anastomose it onto the anus. Okay, we've got a couple of minutes left. We're definitely tracking on time. So one of the last couple of ones that we'll go through is called necrotizing enterocolitis. Now, I think we mentioned this one's much more common in preterm infants and often presents within the first 2 weeks. Essentially what it is, and it's kind of messed up that we don't really know how it works, but essentially just there's like a dead piece of bowel that gets infected, and it just like rapidly progresses, and we don't really know why it happens. There's heaps of research going on at the moment about why it happens and why it progresses. But the two main risk factors from a Monash perspective or an EMQ perspective is that they're preterm or premature, and there's a higher incidence of it in babies that are formula fed. So watch out for those two buzzwords. Basically, they present with like a bowel obstruction picture. So they're really uncomfortable and distressed. They have like fever, vomiting, diarrhea, blood in the stool. You have no idea what's going on, and it's just come out of nowhere. And the complications are basically just death. It's really horrific, and we're not sure why. So if you do bloods on these guys, they have this massive inflammatory response and a metabolic acidosis because there's necrosis happening in the bowel, and so the lactate goes up. And because the lactate goes up, that drops the pH, so they have a metabolic acidosis. The abdominal X-ray, the buzzword for this one is called pneumostosис interstitialis, which sounds very fancy, but basically just means, if you can see it the best on this side over here on the left, you end up with some gas in the wall of the lumen, and that's just where the bacteria are going ballistic. And so that's what that looks like. Management plan, again, your two spoken things, two oral things, two IV things, two medical things. You start them on Ben Pen and Gent for broad spectrum antibiotic cover, and you just get them to the pediatric surgery team as quickly as you can. All right, this is probably be the last one that we have time for. I appreciate we're getting close to time. Pyloric stenosis. So this presents within the first 2 weeks to 2 months of life. As I said before, it's that thickening of the end part of the stomach. And that sort of progresses over time, which is why it takes about 2 weeks to develop. And they really present with this very buzzwordy projectile vomiting. It's meant to like clear the end of their feet. And so they develop this really characteristic picture because they're losing all their chloride from the stomach acid. They become hypo. They have an alkalosis because they're vomiting up all their acid, and they also lose all of their sodium and all of their potassium because they're trying to become progressively dehydrated and regenerate their acid, which is where all the potassium goes into those gastric cells. This is the part of the stomach that gets strictured. These guys are like the projectile vomiting, as I said before. The milky vomit, it's not often bile stained because the obstruction is above a level of the ampulla of Vata, and they have this olive sign apparently on abdominal inspection. So it's a clinical diagnosis. As I said before, they have this sort of VBG metabolic alkalosis, and that's because they're losing their electrolytes in the vomit and trying to regenerate their stomach acid. And the abdominal ultrasound is apparently the best test for these guys. Okay, so that's apparently what an ultrasound would look like if you had pyloric stenosis. Management, again, your baseline surgical workup, and the gold standard surgery for these guys is called a Ramsted's pyloromyotomy, which is basically where they just put a small nick in the pylorus, and that literally fixes the problem, which is quite interesting. And that's what I had for that one. So post-operatively, important to start the feeding process, and hopefully they have a bit of problem with the reflux, but they generally manage really, really well. Okay, just on 11:45, I'll take 1 more minute just to go through intussusception. So intussusception is really the telescoping of the bowel. So one part of the bowel, sort of that peristalsis, swallows up the next part. And I guess the main complication is that the part that gets swallowed up gets its blood supply constricted, and you get a little bit of necrosis, which can be sort of detrimental to the kid because it's really, really sore, and you don't want a piece of necrotic bowel. So 90% they don't really know why. They think it might be the piece of bowel swallowing up some of those lymphoid patches in the Paeds patches in the small bowel, but they're not sure. And then a small percentage have something physical in there, like a Meckel's diverticulum or a hemangioma, like a clot or something like that. That can be the lead point. So you can sort of see that sort of telescoping from lovely Netta's pictures just yet. So when they're really bad, you get that necrosis and bleeding from that patch of the bowel, and you get this really gross red currant jelly stools, which again is quite gross, but that's sort of like why you're getting it, because you've got this bleeding coming from a patch of the bowel that then moves down and can be defecated. On inspection of their abdomen, you get this apparently sausage-shaped mass. I couldn't find one, so I just drew one on this poor-looking baby for the buzzword for the intussusception. For the investigations, again, all the investigations really, really similar: abdominal X-ray and an ultrasound. You see apparently what's called a target sign, but the best investigation for intussusception is what's called a gas enema, where they blow the bowel up a little bit like a balloon, and it sort of opens up that piece of telescopic bowel, and that often self-resolves it as well. So baseline surgical workup and gas enema reduction. Okay, wonderful. I think that's all I got. I had a little bit on testicular problems, but I think we'll probably leave it there. Thank you so much for having me. I hope you learned a couple of things when it comes to Paeds Surg. Hopefully that gives you a bit of a structure to approach it in the future.
Awesome. Thanks so much, Ben. That was amazing. Cool. So in terms of questions, if you have any, send them through the chat or on the Slido. I'm well aware I keep changing the pronunciation of that. But yeah, we'll get to them as soon as we can. But now we've got Evan, who's presenting, and he's presenting on heme, onc, and neurology.
Hey, hello everyone. Thanks for having me again. I'll just share my screen. Is that looking okay?
Yeah.
Beautiful. All right. So yeah, I'll be going through heme, onc, and neuro. I've put in my details there if anyone